I'll start. Um, it's August. Usually in the month of August is when I start reaching out to residents responsible party to get their consent for the flu. So I'm going to be working on that. And also the CDC has approved the 2024 to 2025 vaccine for anyone six years of age and older. So that's going to be releasing sometime this fall. I already reached out to Shopnam about the flu vaccine and the COVID vaccine. It's the estimated time of arrival is still pending. They're not sure when it's going to arrive. But again, for the month of August, I'll reach out to family member, get the consent, put in the orders, and then at the end of September is when I start administering the vaccine. The newest thing about the vaccine is any vaccine that is administered, as if it's pneumonia, COVID, or flu, I need to enter it into the California database. That is now a requirement, and it's mandatory. So if we have 48 residents, that's 48 residents that I have to submit into the California database. And then anything that's left over will go towards the staff in the beginning of October. So the end of September is for residents, and then anything left over will go towards the staff member. And then I'll communicate with Carl to see how many we can order, because I think last year we ordered about 100 flu vaccine for staff. Again, it's optional. It's not mandatory, but it's highly recommended that you get the vaccine. If you decide not to get the vaccine, our policy is during flu season, from October or September to March, a surgical mask. And then for the COVID vaccine, it's highly recommended, but it's not mandatory. So sometime once that comes out, we'll start administering it for residents. For staff, it's not going to be for staff. Last year we didn't. The first 2 years we did offer it, but this year, if you guys are interested in getting the COVID vaccine, you have to go to your local. I was going to say local drug dealer. It's a local drugstore.
If you have a go-to person.
Your local drugstore. Your local drugstore. Not the drug dealer. Go to your local drugstore or to your healthcare provider. Because the vaccine that we received a year ago or 2 years ago, if you have not received it, the effectiveness is not going to be as strong. So they highly recommending us getting updated 2024 or 2025. Hopefully this is just going to be an annual thing. I know that they are working on just providing it annually. Just not much information about it, but the vaccine is not a monovalent, it's not a bivalent, it's a trivalent, meaning that it is effective to fight 3 strains. The strain that's out right now is the H1N1, the H2N3, and the Victoria. As well as the different strain that's out there circulating. So it will cover the existing and the current new one. That's all I have.
Thank you, Sam. Sam is your infection control nurse, and he's giving us an update. Your local drug dealers.
He knows a guy.
Where to find them.
Thank you, Sam.
How do you find those guys? Rosanna stepped out. I was gonna go over the 4 deficiencies that we got from our last survey. It's always good to look at this because it's like a way for us to learn. The first one we got was the F755, which is pharmacy services. We should have medication, OTC, everything pharmacy related available to our resident. Okay, I'll wait for Rosanna over here. We're talking about the 4 deficiencies that we got, and the first one was involving pharmacy related type of disease, specifically the one that we got deficiency for. In this situation, we had a calcium carbonate that was being circled, not given, not given, not available, not available. At some point, we've gone away with some of those, but at some point we were going to get it, right? We were going to get it. And they were actually weren't able to find too many deficiencies, so they were really looking, at the very last day, they were really looking into trying to get us something. And they dug a little deeper and they found this, and the calcium carbonate that was circled 5 or 6 days or whatever, not being given because not available. They interviewed a couple nurses on here. It states that licensed nurse number 1 was interviewed and she didn't know the policy on when should we call the doctor to change the order, right? The other nurse was that, hey, it should be 3 days. After 3 days, when we're circling not available, we should get an order change. Now, in the past, we've always done the 3-day kind of rule. It was never policy then. I don't think a lot of facilities really has that as a policy. It's more or less like that's what we should do when there's an OTC, right? John and I were talking about, kind of continuing with that policy and making it as an effective policy. But as 90% of OTC are really over the counter, they don't pose a significant issue with the resident. But if it's an ordered medication, we should follow through on this medication, right? There are OTCs out there though, like as we talked about in the last couple of days, that are related to a resident's sodium level, right? We're taking sodium tablets. Those are significant type of OTC, and we need to follow through on those. Can you imagine somebody who has a low sodium, we got an order for a sodium tab, and we're like, not available, not available, not available. Meanwhile, this resident is getting tabs and he's bottoming out because we haven't gotten the sodium tablet. That would be pretty significant.
The problem is when it's different people like from outside, they don't even ask any question if the medicine is here or do you know what is this? Because I know some people medication is there, but still they put not available.
Yeah.
But then the pharmacist saw that it was past 3 days. She told me just give it and don't do anything. Anyway, we documented it and I told me to change the date.
Yeah.
Because the medicine, which is
Calcium.
vitamin B12 injection was available. Yeah, and there was somebody who worked here.
Okay. There's a
need to
couple.
ask.
It's not just one individual. It's not the nurse's fault. I'm not gonna say it's the nurse's fault because there was really a system. The way the system that was there, that everybody kind of used, that was it's a failed system. You set up for your staff to kind of kind of struggle, not to fail, but like it's a lot of work that's put into that, right? So you have a system that says, okay, within 3 days you're supposed to call a doctor. It's not available. We did reach out to the pharmacy. The pharmacy didn't bring it in, with the calcium carbonate, right? Right, and we continue to say it's not available. Our pharmacy also has a stat process. If the pharmacy is not able to deliver stat within that 4-hour period, it's supposed to be a 2-hour period, we should be calling the doctor, right? And the policy is not, hey, this medication not available. Let's call the doctor to change the order. We're not here to tell the doctor to change the order. We're here to say, doc, this is not available. This is what we have. What do we do? Then the doctor gives an order. That's how we move forward. Moving forward, though, in terms of OTC not being available and making it difficult for our nurses on the floor, when we do admission, okay, I'm working with our clerks right now. We have this list, and I'm glad Viviana is here. We have this list of OTC. Okay, if the OTC is not available and it's difficult to find, when you call the doctor and verifying all your medication, you should consider asking the doctor, Doc, you know what? This calcium carbonate 500 milligram, 400 vitamin D is not available. We have 600. We have calcium carbonate 600, 200 D. Can you do that? Right? Because the issue with calcium carbonate, when we called the doctor that day, when the surveyor said, what are you going to do with this? We called the doctor and said, what do we do with this? He said, discontinue. It doesn't really even need it. Not that all OTCs are like that, but certainly these things can be changed in an instant, to fit our needs, right? We're still covering the residents' request in terms of their OTC stuff, but it has to be something that we can provide. Okay. The other option, if you're doing admission and the family really wants it, ask them to provide it. Okay, and you don't put the order. You don't put the order to say start when the medication arrives. There's an actual hold order on Matrix. and you hold it until actually the medication arrives, right? We all know how to do that in terms of resources. There's a hold order, and you don't put your nurses on the floor at risk, okay? So when we do admission, again, I'm going to repeat that, okay? We're going to go ahead and I'm going to review this with our clerks. I'm going to add stuff on here, I'm going to delete stuff in there we're not using. If you have something that you want to put in here that we use all the time, go ahead and add it in there, you know, and give it to me, right? I'm going to go over this, and I'm going to put all the milligrams in here. When you're doing your admission, you're like, hey, you know what, I have that on here. And you call it, when you call it, you have to call the doctor anyway, right, to verify this med. Just go over with them. I have 6 different OTC. This is what we have available. These are not available. We can either put this on hold, or you can change it to what we have. Do you see how now you nurses on the floor are putting, you know, they're not going to struggle with these meds and circling and say, oh, let's try to figure out where this is at, you know? So we have to help each other out, and it has to start with admission. Yes, ma'am.
Prep H.
Preparation, okay.
Yeah, we never had that. It was a big problem.
Okay, preparation. Okay, and then if you also have like the milligrams, guys, put the milligrams in here because, for example, melatonin, right? We have like 5 different types of milligrams. You don't need to order all of those because if it's a 5 milligram, there's a 5 milligram. If it's a 6 milligram, you know, if it's a 3 milligram, you can cut the 6 or whatever, right? You can make 5 in 1. Right? If it's a 3 milligram, you can get 3 1 milligram. If it's a 10 milligram, you can get 2 5 milligrams, right? So we can make it work, and if it doesn't work, you call a doctor. If the order is 8 milligram or 5 milligram, and now you want to go 6, that's just 2 milligrams more. You think the doctor cares, right? And if they really want to increase it because they're not, you know, melatonin is that significant for sleep, then increase it to 10 milligram, right? So we got to be creative and try to make this. This is something simple that we can really help our nurses on the floor with, just by being creative with the order through the OTC. We already have enough headaches with these medications coming from Ron's Pharmacy. And remember, Ron's Pharmacy has a stat policy. Put it on them. Order it stat. We're going to pay for it, right? If it doesn't come through, it's on record. We order the stat, and then we can change it. Okay. At any point in time, if we actually put an order in, it's not available. We thought it was there. It's not available. You can always call the doctor and have it changed. Okay, and then remember to communicate with family members. This is what we have. Okay, if you want to go in and around that, you can provide it for us. In the meantime, we don't hold. Okay, yes, ma'am.
Can you add melatonin 5 there? Because you only have 3.
We have 1, 3, and 5 there.
Okay.
Yeah, 1, 3, and 5.
Because it's over here it says only.
Oh no, I erased that. I have another list.
Oh, yeah.
Yeah, we're gonna order the 1 and 5 milligram.
Is
So,
that-
yes, ma'am.
So is that possible when OTC order, sometimes Matrix and facility stock,
Yeah.
but it's not.
So I called Matrix.
Yeah.
I called Matrix today, and I asked them. I said, "Who's responsible for making these stock orders for our Matrix?" They're like, "Oh, it's like an algorithm. Whatever you're using the most, and it's not just our facility. It's like, yeah. So that would be your stock order." And I'm like, "Well, you understand that doesn't really help us as a facility because you're saying that's our stock, but it doesn't match our actual physical stock." So I was like, can I get an access to it so I can actually put whatever stock we have in there? Oh, we don't have the capability. It's just what is the most common used stock OTC is what we put in there. But we've seen most common stock OTC. That should be like, right? It should be stock, but it's not. It's at the very bottom. So when you are putting in your stock orders, OTC, just make sure you are looking at the very bottom too. The same thing, like you might be under brand name, it could be under generic name or whatever, but it's there. You just have to be a little bit more, you know, have to play around with it. Certain types of OTC too, you might change the milligram and kind of tweak it around, but you are going to get there in terms of trying to get those orders in. Okay. We talk about too today, some of your per diem or registry staff, they might open some OTC stuff that's already there because they can't find it. So to make that easier, the communication between nurses when you're taking orders and the floor, it's got to be a little bit better, right? For example, if the medication is liquid, it's usually on the 3rd level, and then it's going to give the nurse on the floor a hard time to find it. You can put on there special order instruction. It's on the 3rd level, all right? There's Align antibiotics, right, or probiotics. People are going to think, right? If you're a new nurse, you're going to think that's tablets in a vial. That's literally in a packet, right? If you see it, it's got to be on a packet. Special instruction. It's easier to find than trying to look for a vial, you know. for us, we've been passing meds for 20 years. It's fine. You have nurses seen that are coming in that are 1 year, 2 years registry. They're the ones that are going to be like, where's everything at? And you think it's not going to affect you when you come back the following day. They have your card upside down now. Now it's affecting you, right? So we gotta be proactive in trying to help these guys because they're not gonna go away unless you think you're gonna work 24/7 and cover all of our missing spots, right? So we need to be creative in a way that's helping other nurses because it'll help us out later on, you know. So I was telling Leslie that you have something like this and you know about it, you know, fix it on your order sheet so that way it kind of it goes over as a communication between you and the nurses on the floor. You know exactly what's at. It kind of helps them out, you know, because it could take them literally like 2 minutes to find that OTC.
Again, it took kind of 10 minutes. It could be a lot, 10 minutes.
Yeah.
And they need to ask for help too. They need it because
Yeah.
I don't know. I don't know what drawer something's in either.
Right.
You know, but if they ask for help, I can help them.
Right.
Look.
Certain
But they need to, you know, ask for help.
Yeah, certain OTC will be very specific, and it's gonna be shoved somewhere, and you can be specific on that order. It's gonna be found here. It's gonna be in, and that's why you have the special instruction, because you can edit that order, right? Yeah. So, also these guys will keep opening. I've noticed that there's a lot of OTC that are open. It's because they can't find it. They're just not opening stuff, and they were just throwing it away. You know, just getting
They
it
don't
out.
ask.
Yeah. So, and sometimes Blanca's pretty good too. She'll go in there and kind of help out. Anyways, I'm going into the weeds here, wasting your time, but it's just a way for us to be more efficient in terms of, you know, med pass. But we're changing our policy in terms of if an OTC is not available, yes, we're going to need to call a doctor right away, okay? Because that should be taken care of at admission. If OTC is not available, it's not in stock physically, we need to be calling the doctor. We need to be verifying with the doctor to make sure that whatever's on here, okay? Not everything that's going to be from the hospital is going to be on here, okay? There's certain things, and those things we might have to order and then put a hold order on it until available, okay? But don't put an order on it if you know it's not available, guys. It's just, and you know, I know you're not going to know everything because you're writing so many orders, and you're not going to, you know, it's hard to check every OTC whether it's available or not. But I'm hoping that this list can give you, you know, some guidance, you know. And then, so if you're passing meds, again, the new policy should be if it's not available, you need to call a doctor right away. And they might just DC or change it right away. Just say, hey, you know what, doc, you know, vitamin with minerals is not available. We just have vitamins. Okay, let's change it to just vitamins. Okay? But there's no longer a policy or a trend where we're saying we're gonna wait 3 days, keep saying that's not available. We have to act on it. We have to act on it right away. Okay, get it changed, call the doctor, see what he wants to do. Okay, so that was the first efficiency that we got, and then our overhaul would be changing it from admission standpoint, and then if there's any if you can call it in stat right away. Okay, because that's available to our servicing our pharmacy services, and then call the doctor right away. The other one is, and they go over, you know, the nurses that was interviewed, all that. 758 psychotropic medication. This one, I've been there. I get it, guys. There's an order for a controlled substance. It could be Ativan. It could be whatever narcotic. It's usually BID. Now it was changed, and you memorize everything. So you're just popping everything, you know, giving. They're gonna catch that somehow. If they're really digging in to try to get you a deficiency during annual survey, they're gonna find it, right? In this situation, you know, the nurse did confess that, hey, you know what, that's what happened. You know, I thought it was BID and it was QD. Okay, so you just gotta be very careful, you know, in terms of what we're giving, because controlled substance is they were trying to make that as if it was a what's the phrase? I got it today. It was the first meeting at 7 o'clock. Conversion, right? They were saying that's we're trying to hide something. We're trying to, you know, take a, you know, what I was trying to explain is that who's going to take Ativan? You know what I mean? Like, you have a severe anxiety problem that you have to pop Ativan and do it, right? But it does happen. It doesn't matter how it happened, and they're going to try to get you as hard as they can on it. Okay, so make sure that what you're giving, especially these controlled substances, these narcotics, you know, whatever the case, even Ativan, Xanax, right? That you know, you're looking at the order matrix, and it's matching, right? The order on the whatever you're signing in, and narcotics, the control substance you're signing in, that's not necessarily the right order, right? And the right process should be, if it's changed, you get a sticker that says change of order, right? That doesn't always happen, okay? You're trying to figure out, okay, it's VAD, and then you're gonna go with that order, right? But the matrix is totally telling you something different. Okay, so that's how we got for that psychotropic. The other thing with the psychotropic is that this medication has a. Have you heard me talk about this frequently? That psychotropic medication has to have diagnosis and then has to have a behavior. Okay, this medication we were giving was Ativan for SOB for PRN, right? And we're giving it for yelling out. You know, we're documenting Ativan was given for yelling out. There's nowhere on that Ativan order that it was supposed to be given for behavior. It says shortness of breath. Okay, so you gotta be careful when you're getting PRN Ativan. Make sure you're getting the diagnosis. Okay, the diagnosis could be depression, could be anxiety, you know, and then behavior, yelling out, shortness of breath, or whatever, right? So anything behavior related. So get your diagnosis, get your behavior, and you jot it down on that order. Okay. If you fax the doctor an order and you stated something that this is given for this, and then something was omitted, you're gonna need a clarification of order. You're gonna have to write it again and say, hey, you know what, doc? Actually, I need you to put this in there. Is this okay if I put this for this indication? And he has to say okay on it. Okay. And if you don't do that, write it down. Make sure you're writing it as a TO in the nurse's notes. Okay, somehow, some way, the doctor gave the order, not we gave the order. Okay, so just making sure that we're going back to basics. When you take an order, you're clarifying things via TO, telephone order, and then you're writing down in the nurse's notes or in the TO form. Okay. 14 days for PRN Ativan or any psych med that's giving PRN, right? 14 days. We got to make sure that we follow through on these orders. If it says reassess after 14 days, you can't give that medication anymore unless you get another order. Okay?
Oh, if it's a hospice order.
Yeah, if it's a hospice order and it's ordered 14 days, and the
Is it still 14
doctor
days?
says,
That's not the way they
yeah, it has to have a doctor's note in there that they can continue to use it, you know, for symptom related because you know they're in stage or whatnot, right?
hospice doesn't write 14 days.
Yeah, and we want to make sure, and see, that's where the green line is that.
And
so
they
if you're
also
a
write
resource-
5 different behaviors on the Ativan. Like the one I had last night, like the guy in 14.
Yeah.
They wrote Ativan for agitation, shortness of breath, nausea, vomiting. They wrote for like 6 different things. And it's every 4 hours as needed. They wrote it for like 5 different indications. On behaviors, I thought, well, of course they have one. Hospice doesn't write those words like that. That's North Coast.
North Coast Hospital. Is she actively dying? She's
Yes,
like
yes,
she's in stage
yeah,
obviously,
yeah,
right?
yeah,
Okay.
exactly.
Alright,
This is so
I'll
much
reach out to
pain.
Shad now, but I think
This is so much pain, and they increased the price,
Yeah.
and they're gonna bring a comfort kit. I think they're supposed to probably already here.
yeah.
Yeah.
And so that's the thing too is that how do we know if the doctor is writing these things down that you're supposed to continue within after 14 days, you know, with hospice. So we'll get that clarified, but I think after 14 days and they're not hospice, you're still on Ativan or Xanax or whatever, you're gonna need you need to reassess after 14 days, okay? But usually hospice, after 14 days, you can continue it so long as the doctor's saying you're still in hospice, you can continue that. I think that's the indicator there is that I'm still in hospice, I need this for symptom management. Is that, but if you're off hospice, you're gonna need that every 14 days. Okay. Yeah. What's the other thing with the 14 day? The routine and the PRN is totally different. You're counting the amount of behavior that's on the routine, right? Because you want to decrease or increase it.
Behavior frequency.
Yeah, behavior frequency. But for PRN, you're not counting these behavior because you're already giving it for a specific behavior. Okay, so that's the difference between the routine and PRN when we're counting every month. Which shift counts up, by the way? PM or NOC or AM?
It's every shift, behavior frequency.
No, when you're counting at the end of the month.
30
No,
days.
not sure.
Yeah.
They do the summary.
Okay, the summary. So for the routine, we're counting every behavior, right? At the end of the month, if there's no behavior, we like decrease the dosage or whatever. For PRN, we don't have to do that, right? And it's because you're already giving it for a specific behavior. So we're not really counting it. So So that is new to me because I was like, we need to count these behaviors, but it makes sense that you're not counting it because you're giving it for a specific behavior. Yes, ma'am.
So you're saying specific behavior. If the order is applicable for shortness of breath,
like six
anxiety,
different
yelling
things.
out,
Yeah.
screaming, whatever,
it has to
how
be.
could you?
Yeah, it has to be
Yeah.
like, very specific, and we could break those down too as nurses. I know the
It's difficult.
hospice nurses are writing them down in a different way, but because it could like somebody could carry that out in the wrong way and kind of like shorten it, right? Shortness of breath, behavior issues, whatever. But you could write it down just like you would with Ativan for Tylenol, 325 for fever, Tylenol for mild pain. You do that, right?
Yes.
Have you guys seen that? We do
Yes.
the same thing for Ativan.
Yeah.
Okay.
But when you give it, can't you just add a comment that given for shortness of breath or given for yelling out, or given, if that's part of the
Because
order?
sometimes that
The monitor
resident
the
needs it for
behavior.
more than
Yeah.
one indication.
Yeah,
The
so if
behavior
the
you
order
have
says
to-
I'm
they
giving
need
it
it
for these
for,
different
like, 3
behaviors,
indications.
you
Yeah.
specify what that behavior
Well, I think the
was that
behavior
day.
part, where you they want it like a specific behavior. If it's anxiety, what kind of anxiety you have, yelling out,
They want
right?
a
So, but
description.
agitation, anxiety, I think those will also be put together. Except for shortness of breath, that's like totally different, right? You should have added by order for shortness of breath. Your behavior should be totally separated from everything else, right? And it could be you're having shortness of breath and you're having
Anxiety
secondary
attack.
anxiety and now you're yelling out. But
Yeah.
I mean, that's just how it works in terms of how we need to monitor these behaviors. And
It's difficult. It's a big gray area.
yeah.
Like
So
Gigi, when she gets
a specific. This is what we got. A specific behavior was not documented. Right? A specific behavior was not documented in terms of that they got us for that. They want to be very specific. Now, could it be just this surveyor that's being,
Picky.
being difficult? Maybe. I mean, I don't
we could write it
remember.
out.
Oh yeah, we have gotten that.
the same
We've gotten
order
this
several
deficiency
times
before.
for different behaviors.
This is why this is how we know it because we've gotten this before. I remember getting this deficiency before
Yeah.
for a specific behavior. Yeah. I remember having antidepressant, right? And then they had 2 different behaviors, and we got a ding for that.
Yeah,
Like,
you gotta have
cannot
one
have
behavior
2.
after
It has to
one
be
behavior.
one, yeah. And then who knows those better than anybody? It's gonna be the nurses passing the meds, right? A lot of times when you do admission and you're putting in monitor for this behavior, you can leave it open because you don't know. Literally, you don't know. As you're passing your meds, though, the nurses on the floor should be adding behavior on there, monitor for a behavior exhibited by whatever. We should be putting those in. Don't wait for your resource nurse to put them. You know what I mean? You can literally put those in there on your own,
Yeah, put something
right?
on
Because you're the one that's seeing this behavior, right? So we could do that. All right,
So
the
for
other
the behavior, if we click the behavior, then nurse can write down the comment, right?
yes, sometimes. Do they do that still? Are you able to do that? They have like a very short, limited amount of behavior,
But
don't
when
you?
you give the med, you can put in a comment.
You can add a comment, but you can't
Yeah.
click it off. It
No,
doesn't give it
just-
to you.
Just how many times?
Right.
You've seen that.
Yeah, yeah.
Like how many times is someone?
I think I have seen that before, but it was in paper form. Remember? Yeah, because
be
we're
helpful.
both old nurses. We know, like back in the days, you can click off like whatever the behavior is. Yeah, in the Matrix, it doesn't give you that.
Nice and
Yeah.
popular.
Right.
Yeah, it doesn't give you that. Okay. All right. What's the other one here? F842. Resident records identifiable. This one we had some issues with. The surveyors were very specific and they were very pushy. You know, they wanted to give us a deficiency for certain things, and I had 3 or 4 times I had to come in and say, "Here's the record," and then they would take off the deficiency. One time they went into the months, I'm saying, in resident in the East Hall, and she said she's had multiple falls. She's got a rip on her fall mat. Can you explain to me why I shouldn't give you a deficiency for that? And I'm like, well, with all due respect, she doesn't get the fall. That could be a fall risk for us, but I don't see how that could be a fall risk for her because she's bed fast. She said, okay, we'll fix this rip, we'll get a new bed mat, and then we'll take this off. And so that's what we did. We got that. But like, you can see how ready they are to just give you deficiency, right? And you could, at the end of the day, you can have 20 of them, you know? So and there was one where this one really like irks me because like she was like, okay, where is the there was an order for a resident who was supposed to get a pneumonia vaccine, and there was a note in there given upon arrival. Okay, and then it arrived, I guess, right? We never gave it. Somehow we never gave it. She found the record, and she found it because there was a note on there. And this was like 6 months later. Yeah. So she found it. It's like, what's going on? And it was like, I showed her. I said, well, she got the pneumonia vaccine within 10 years after 65. She got it a couple of years ago. She's like, yeah, but there was an order. There was an order to give it. You guys never gave it. So it was a deficiency moving out of that room, right? And I'm like, I couldn't prove to her. I was like, I don't know what to tell you because yes, you're right. It looks like we just missed it. So Alexa comes around and she's like, well, yeah, it looks like she got the vaccine, a couple of years ago. Oh, okay, that's fine then. That's good. I'm like, but that's the same thing I said.
Yeah.
She's like, oh, Alexa saved the day. I'm like, well, okay, never mind. No, that's good. I was like, yes.
Yeah.
And I didn't want to be like
That's fine.
I was like, I told you that. But I'm like, okay, that's great. So, because I'm like, they came out of Alexa's office and like, oh yeah, I just found it. I was like, what did you find? So I'm just like, what did you find? It's like, oh, I found that she got the vaccine like a couple years ago. And I'm like, okay, yes, yeah, okay, great. I'm like, okay. So anyways, it was just like that type of survey. And then the other one was infection control, where we actually touched the food without gloves. We were trying to help a resident out, and in the dining room, it was a sandwich. We did have hygiene, but we didn't use gloves. I mean, we've never. I guess we've kind of stayed away with gloves. We trained our staff to not pass med, not walk around the hall with gloves. So gloves in the dining room were like, we never really.
There should be different gloves
Because
in dining room. They should be the white ones, not what we use for.
But here's the thing, right? Like, if a resident can't eat on their own,
Yeah.
right? If they can't grab onto the food, why do they have a sandwich to begin with, right? You should be able to feed them with a spoon, right? So why are you having a sandwich if you can't, So that was changed, but still, it's one of those where she did have hygiene because she was kind of scared too. She was like, I don't know, should I wear gloves here in the dining room? Resident? And there's so many rules into feeding a resident that it's just. Anyways, we took that one. That was one from our
I have a
side.
question.
Yes,
So
ma'am.
do we have to wear gloves now every time we feed patients?
Only if you're touching the food. If you're touching the food, like you're picking up a sandwich, of course you're gonna wear gloves, right? Yeah, you're gonna.
But with the spoon and...
with a spoon, if you have the spoon, no.
But
But you're not
no?
touching the food.
Okay.
But if you touch the resident physically, you're gonna have to do hand hygiene.
We
okay.
always touch the patient.
Yeah, I know. That you're gonna have to avoid that if they're here. Avoid touching your resident because you're gonna have to do hand hygiene.
Because sometimes we have to reposition them, they're eating,
Yeah.
we have to
You're gonna have
reposition,
to
we're
do hand
touching the
hygiene. Yeah, hand
patient.
hygiene. You're gonna have to do a lot of hand hygiene when you're doing.
You
when
stop,
you're
wash your hands, don't.
Yeah. So you might lose, a couple minutes here and there, but you just gotta. The more hand hygiene you do, the better. If it's questionable, do hand hygiene. You know what I mean?
Okay, so when we check the meal tray, wear gloves?
You're not touching any food. You don't have to wear gloves. Okay, no gloves in the hallway. So you can do hand hygiene or whatever for each resident that you're going into. That's why we have the little hand hygiene outside. You can do them. So it gets pretty kind of hairy when they're here, but the more even just going in, right? If you're not touching the resident, literally you don't have to do hand hygiene, but just to be safe, you can do hand hygiene, right? If somebody is on isolation though, and you're not touching anything, you're just dropping by, and it's 6 feet or whatever, then you do have to have a hand hygiene, right? Because you're on isolation. Okay, and that's what's explained to me by a surveyor. Whether they're making that up, I'm just gonna have to take their word for it and just do hand hygiene.
So with a patient with COVID, every time they finish their food, we put them in a plastic bag and they can, no, we don't do that?
we don't do that. Yeah.
Don't do it?
No, we don't do that.
it.
Where?
So-
Where?
In South Station, we have a patient with COVID.
Oh.
So after she eats the tray, we put it in a plastic
Yeah,
bag
yeah,
and we take it to the
Yeah.
kitchen. No,
Well, who are you protecting in the kitchen?
I don't know, but that's what we
Because
do.
they're washing their hands, they're gloved up, they're bodied up.
So no, do not.
No,
Yeah,
no,
okay.
you don't do that.
Okay.
Yeah, we don't have to bag it up. Yeah.
Put it all together in one.
And it's droplet, so unless
Droplet,
you're
yeah.
like not washing your hands, not gloving up, and you literally eating off the plate, you're not really gonna get infected. Washing your hands, hand hygiene after you touch anything should be like standards over there. know, that's
Okay,
just
so
normal
don't
for them.
put it in a plastic bag.
No,
Put it back in.
yeah,
Okay,
just put
so
it back in
just,
there.
you know.
Yeah. Okay, so any questions, any more questions on the survey there? Alright. Okay, alright, so those are the surveys. Oh, communication too, guys, just make sure, we do a really, I don't know, what do you call it, like buttering these guys up when they come in. And most of them are really nice. The two ladies that came in, they're pretty nice. They're here to give you a deficiency. They're not here to say you got a perfect little place here, okay? No, they have to come back with some form of deficiency, right? So, but overall they were really nice. But they're in a situation where you're talking to them, you want to avoid triggering them, And I'm not gonna say specific individual or whatever that triggers them. Because sometimes we get to that situation. I've gotten surveyed before where a surveyor keeps asking a question, I keep telling them the same thing, and I've gotten triggered. And I'm yelling and screaming at her, and Carlos right there. And Carlos like trying to say, oh, no. But we have to really control your emotion when you guys are talking to them, okay? If they ask you something and say, hey, why is it this and that, you can't just say, hey, it's just OTC. Oh, I don't know, it's just, I ordered it, I don't know what happened after that. That's not something we want to tell them, If the cart was left unlocked, right? We can't say, I don't know who, somebody went in here, I don't know who opened it. You can just say, I'm sorry, I got kind of busy or whatever, go and turn around, lock it up, but like, getting into like a tense situation with it is going to make things worse. Okay, so communication is going to be really important with these guys. Okay. Admission. We talked about the OTC. Look through it, please, and add stuff in there. Take off some stuff if you don't feel that you should
You
be
need to add
there.
hydroxynine, HCl or Atarax, because we're just not using like
Is
that.
Atarax OTC?
No.
It's
That
not.
one's
it's
that
not.
should be on the.
Yeah.
I thought it was OTC.
That's in the
The
cubic.
cubics, yeah.
Okay.
Yeah.
I thought you got it from the bottom. I didn't. And the sodium tablet.
Yeah, I got it.
Palladium.
Sodium.
It's palladium.
What do you guys know the regular sodium tabs?
It's
Is it
1
1
gram.
gram?
1 gram. It's
1
always
gram.
1 gram. Yeah, 1 tab, 1 gram.
Palladium is an OTC too, but it's also prescription.
Yeah.
Iridium? Yeah.
It's a
Pyrex or something like that? Or is that like the Tupperware they're talking about?
For the UTI.
Pyrex?
Palladium. It's called
That's the
That's the Tupperware.
Pyrex is Tupperware.
Yeah, that's
iridium, right?
Pyrex.
That's the prescription.
I haven't passed meds in a while, so. Okay, so let's go over and talk about the role of the nurses on the floor. If there's no resource nurse, guys, you're responsible for all your residents, whatever that situation is, right? If pharmacy wants to review medication with you, you can't say, I'm gonna wait till the resource nurse. When the resource nurse called out to me that day, it's running late, it's not my job, it's the resource nurse. Okay, if it's your resident, that's your responsibility. Okay, so that's kind of my criteria in terms of the floor nurses and the resource nurse. Okay, it's our resident. The resource nurse is there to complement you. Okay, to help us out.
I have a question.
Yes, ma'am.
On the eardrops, do we have that,
The G-Brox?
yeah, well, we have the G-Prox, but after 3 days you have to irrigate it.
Yeah,
We
we
don't
have
have that irrigate.
Yeah, we do.
irrigating.
No.
We have no, we don't have the irrigation for the ears.
Yeah, we don't have.
You use a syringe.
Did somebody
You know, a
lose it?
syringe.
It seems like
The
some-
water-
We used to have it, but I guess it was thrown away.
because
Oh, yeah.
Blanca said it's for the
It was for the nose, but no, it's not. It's for the ear.
Yeah.
It is for the
It was for the ear because every time I use
I'll take a look
it,
at it.
Yeah.
every
When
time-
was the last time you guys seen it?
So
I
That's
was
why we
there
don't
like
have.
2 months
It's
ago.
been gone.
A long time
It's been
ago.
gone for
And
a
I
while.
asked Blanca, and I
Yeah.
guess, it was thrown away because, somebody had told her that it was for the nose. But that was for the ear. And we had that for a long, long time, and it works. Every
That
time I
is
use
good.
it,
Yeah,
it
it's
works.
Nice, yeah.
Okay, we'll order another one. Those things are like $30.
I know, but this one was you charge it. It's
Yeah.
not just the manual.
Okay. No, we get the same one. I know exactly what
Yeah.
Like a water pick.
Yeah, the water fish, yeah.
the bionics. is
Okay.
$2.
Okay, we'll get another one. Training, make sure you guys do your annual trainings. Not a
Is
lot-
it, I think it's already done.
It's already done, yeah,
It's
yeah.
been
But
over
every
with.
year, we've had a couple CNAs that are affected with their rates. I don't have control over that. If you don't do your annual training, HR is gonna automatically say minus whatever this much, and then by the time we even get to the annual raise, it's already done. Okay, so please do your annual training, do your annual physical. Oxygen room, I think I sent a video on that. If you haven't watched it, just take a look at that. There's specific things that we need to do on there. We've had some issues with cubics, and I want to kind of address it. The cubic system lately, there was an issue with the morphine, and the issue was that the morphine was actually the latch on it is messed up. So no matter what you did with the morphine, you try to put them in there, it wouldn't pop out. It wouldn't pop in. It wouldn't like accumulate, right? So we had to have the tech come through. They fixed it. We re-added it on there. Now it's available for everybody. Okay. There's also another cubby that's out. It's broken and it doesn't latch. So that's out. And then luckily we switched that Norco to the Jelly Bean. So the Jelly Beans is out, and but everything else should be in there. All of your narcotics should be in there. And but we have one missing part, which is the Jelly Beans that's out. If you have issues with latching and stuff like that, please just let me know. Send me a message or whatever. The other day we just could not even use the cubics. It wasn't working, and I had to get somebody to come in here and try to fix that. Okay. Certification, oxygen, psychotropic. The other thing we can do, guys, resource nurses working. There's usually every month or so we have these psychotropic recommendations from the pharmacy. Okay, when you take these psych meds, they will send this recommendation either decrease or do labs or increase or whatever the case may be. It's a recommendation from the pharmacy. It has to go through the doctor, and so a lot of these are just lab orders. So as resource nurses, work with your clerks, have them figure out the lab, not have them figure out, just let them know they need labs for this or whatever, and then carry out the order.
Is that going to be in the desk now?
It's gonna be in the desk now because there's not one person right now that's able to carry this out. Yeah. But he has to go. It's appropriate that it goes to the desk because these are things that There's about 15 of these that come, 15 to 20 maybe. Okay, and it doesn't have to be done all in one day, but it has to be
What's
done.
little tabs for? That's a month?
This is June, yeah. These are monthly. So, and then we just basically have to carry out these orders. We fax it to the doctor, we call the doctor, or whatever the case may be, how significant it is, have the doctor make a decision on
Back
it.
in the book?
Yeah.
Or put it in the chart?
The other thing is, there was an issue with a sheriff coming in a couple of days ago. Make sure any sheriff, any police department coming in, make sure you notify Ja or Carl. Okay, there was a sheriff that came in, and I guess nobody knew they were coming in. Some kind of signature they had to do. 15A, you guys know what I'm talking about. 15A, she keeps calling, she keeps reporting.
Going home.
Make sure, we're trying to do LCD on her. Make sure that when 15-20 minutes is a very long time, guys. And then we have a $60,000, $70,000 call-out system. If your CNAs are not picking up, you have to use your radio to call them and get them to pick it up. It's 15 minutes for anybody, not just 15A. It's going to be really long. Okay, we're shooting for 3 to 5 minutes at the highest. Every time she calls and say, hey, you know what, I've been waiting, and it can be confirmed by this call light. Okay, so we're going to need to overlook her CNA. If CNAs are not available, we're going to have to pick up these lights. Okay, and make sure that you know what, that.
But can you check how many times she calls, because she calls a lot.
She calls quite a bit, and we average
actually been calling for us
pretty good.
lately.
You know?
But the couple times on knock shift, right? She called maybe 4 or 5 times in the whole shift. It wasn't a lot, but at 3:30 in the morning she called, and then it lasted 20 minutes. And so we want to make sure those are okay. Okay. Last couple things here. Documentation, discharge, guys. I don't know why we're not adding discharge notes on here. You have to note in there to discharge this resident on the nurse's notes at this time or whatever, where they're going, at home, in the hospital, assisted living, or whatever. You just have to know. When I'm doing my report, sometimes I'm looking at this, and then a couple times Jai asked me, he's like, where's the notes for discharge? I'm like, I don't know. We can track it. Joanna, a lot of times she'll add them on there, but as nurses, we should probably put it on there. You know, she left at this building at this time with her family, you know, just to be safe. You know, so that's records indicating that, you know, you did a good, safe discharge. And those are really good notes to have, because there's some notes in there where the patient was just like, all kinds of notes, and all of a sudden it stops. Like, where did this patient go to, right? And I had to look in the observation to figure out, she went home. And so, question, okay, and the other thing with orders is that everybody is really liable for an order. If our order is written, not only the doctor is liable. Okay, there's 3 people that's involved there. There's a doctor, there's a pharmacy, there's a nurse. Okay, if the order doesn't fit and that looks kind of weird, you should probably question it or change it or call the doctor and be like, hey, what is this? You only did 6 milligrams, right? You should be taking 1. You know, there's the INR. What's going on? But always question it because everybody like it. Everybody like it. Okay? Not only the doctor, like I said, the pharmacy and nurses as well. Okay? Any questions, guys? On anything? Okay. All right. Make sure you sign in. Thank you.